Now moving on to the next section, that is the radial nerve and suprascapular nerve compression syndromes. In this, we will be briefly going through the posterior interosseous nerve syndrome, radial tunnel syndrome in the forearm, and lastly, the suprascapular nerves which can get compressed in the shoulder level. So as you know, that radial nerves descends all the way from the posterior compartment of the forearm. In the arm, it can get compressed in the radial tunnel, which is actually in the shaft of the humerus fractures, which can especially be very damaging, especially in traumatic situations. Or once it actually crosses the elbow, it has already given off branches to them, two of the muscles, then for example, the triceps and all that, and then it descends down into the posterior compartment of the forearm, forming the posterior interosseous nerve and giving off a few branches to the other muscles such as extensor carpi radialis longus. This is important because we will be discussing whether it is the posterior interosseous nerve injury or radial nerve injury, how to differentiate clinically between the two. As I've just shown you that it can get damaged over here, that in the just below the elbow where it actually entering into the forearm and leading to posterior interosseous nerve injury, or it can get damaged 3 to 4 centimeters below the lateral epicondyle in form of radial tunnel, where actually the posterior interosseous nerve enters into the radial tunnel, leading to radial tunnel syndrome. And others rarely, but usually it can get superficial branch of the radial nerve can get damaged with associated with the scaphoid fractures or wrist trauma, usually on the radial side and with extensor surfaces of the wrist. So we will be going to the posterior interosseous nerve compression syndrome. That is, it can get compressed at 5 areas. Its mnemonic is FREAS, FREAS. That's a very simple thing. F stands for basically flexor muscle mass, and then there is fibrosis of actually bicipital neurosis. Then the R stands for the radial vessels which form a leash of Henry. Then there is, it could be get compressed with extensor carpi radialis brevis H, where it can get compressed, or this can get compressed at actually the arcade of Frouche, where is also found by the supinator muscle, or it can get compressed at the edge of the supinator muscle in form of, and S stands for that. So F is fibrosis, R is radial vessels which form leash of Henry, E stands for extensor carpi radialis brevis, H is arcade of Frouche, and S is the edge of the supinator muscle. This could be any other cause as well. It could be space occupying lesion of the elbow, it could be some kind of a tumor, it could be hematoma which can actually compress the posterior interosseous nerve injury, ganglion, lipoma, or even the radiocapital synovitis can all lead to pain injury. Two clinical patterns actually noted. One is posterior interosseous nerve syndrome or radial tunnel syndrome, and there is a slight variation between where they can actually the symptoms overlap, but there's only the variation is where the nerves can get compressed. In pin syndrome, the nerve I told you can get compressed at a 5 side. Now this is the posterior part of the elbow. The radial nerve is actually dividing in, and it's actually giving off the branches. Now this is already the branch being given to extensor carpi radialis longus, and it continues as a pin. Once it continues as a posterior interosseous nerve, it can get compressed at 5 areas, which I told you it is it's a pure motor disorder. Why? Because it has no sensory supply. So if in case of posterior interosseous nerve injury, there will be only muscle paralysis. There will be no sensory loss, which would be seen in the posterior part of the forearm as well as the wrist joint. There will be weakness of metacarpophalangeal extension because extensor digitorum indusus and extensor digitorum communis has been supplied the pin. Therefore, the patient will be either unable to extend the metacarpophalangeal joint, or there will be weakness of it. There will be wrist extensions will be although preserved. Why? Because it has already given a branch to the extensor carpi radialis longus. But once with a pin injury, the patient will do the wrist extension, there will also radial deviation. This radial deviation is because the extensor carpi radialis longus is not only extending the wrist, also radially pulling it. Therefore, with the pin injury, the classical sign is the patient once tries to extend it, there is a radial deviation along with it as well. Weak extensor carpi ulnaris as it is supplied with pin, so therefore the countering force extensor carpi radialis longus is not done by extensor carpi ulnaris. Therefore, extension of the wrist joint results in the radial deviation of the wrist. as you know that it can get compressed to 5 areas. That is the fibrosis of the first area. Then there is radial vessels which form a leash of Henry around the posterior interosseous nerve. Then extensor carpi radialis brevis edge. This could be at the arcade of Rouge, or it could be edge of the supinator. Treatment, usually how we diagnose is by the MRI, and the option is either surgery. The surgical repair can be done at 3 to 6 months, but if it's beyond 6 months, usually we have to go for tendon transfers. The flexor muscles which are normal have to be transferred back towards the radial side, so the wrist extension and metacarpopharyngeal joint extension can be restored. Now coming to the radial tunnel syndrome, it's actually still the compression of the nerve as well, but there's only few differences. Clinically, we have to differentiate from tennis elbow. Tennis elbow is actually a pain of the lateral epicondyle. It's called as lateral epicondylitis, which leads to the irritation of the extensor carpi radialis longus and extensor carpi radialis brevis. But that is lying at the just lateral to the lateral epicondyle. While this radial tunnel syndrome is actually the pain and numbness and problem starts 3 to 4 centimeter below the level of the lateral epicondyle. You see this is the diagram showing the tennis elbows at the level of lateral condyle, while the radial nerve getting compressed in the radial tunnel is at 3 to 4 centimeter below the level of the lateral condyle. Usually it's actually also labeled as a resistant tennis elbow, because even the patient has been, what happens is the patient gets treated off and on in form of physiotherapy, steroid injection for tennis elbow, but actually the pain is of the radial tunnel, not of the tennis elbow. Therefore some books mention it as a resistant tennis elbow. There could be pain, and especially pain with the resisted extension. The patient extends the wrist joint with forced flexural extension is done with a pronated arm. This can lead to severe form of pain, especially over the 3 to 4 centimeter below the level of the lateral epicondyle. This is a provocative test and actually explains how we can differentiate tennis elbow from the radial tunnel. There is single motor nerve involved, therefore usually there is loss extensor carpi radialis longus and brevis mainly. Electrodiagnostic studies are not useful because it cannot actually predict the loss of all the muscles, but it's more of a clinical symptoms rather than clinical. We can appreciate it from tennis elbow rather than any use of any NCS and EMGs. Treatment is surgery, that we have to release it in such fascial release is important so that the nerves does not get compressed between the two heads of the ACRL and ECRB. Coming to the suprascapular nerve compression. Now the nerve which can supply the supraspinatus muscle and infraspinatus muscle can get compressed as it descends below the suprascapular notch to supply. In this diagram you can appreciate it where the suprascapular nerve is descending down, and it can get entrapped with this ligament. It can get entrapped at this level as well, when a ganglion or cyst or any form of a mass or a lipoma can result in loss of muscle surface which is it supplying, which is supraspinatus and infraspinatus. So it is actually chronic or repetitive compression of suprascapular nerve and its branches is much more common than generally recognized, because usually it's associated with shoulder pain and loss of abduction, and people thinking about the rotator cuff muscles are involved, and mostly the differential include rotator cuff tears, rotator cuff syndromes and all that. So we have to keep that in mind, that this could be simply suprascapular nerve compression. Symptoms are as of rotator cuff lesions. That is why it usually rarely diagnosed, or it's actually kept in differentials, but it is actually more common than it is diagnosed, because usually we diagnose the rotator cuff lesions. It may be associated with cervical radiculopathy. Compression could be at suprascapular notch over here, or at the fibroosseous tunnel which is just below the spine of the scapula. So causes could be a continuous pressure, repeated traction. Continuous pressure could be in form of cyst. This could be in form of a tumor, or it could be in form of a lipoma. Or repeated compression could be due to in case of exercises which involve mainly the muscles such as supraspinatus and infraspinatus. Clinical features would include there would maybe associated a previous injury to the pectoral girdle. There would be pain in the suprascapular region, weakness of the shoulder and upper arm movements. As you know, the supraspinatus is the initiator of the abductor. Therefore, the patient will have problem with the initiate abduction. But once it crosses 20-30 degree because deltoid is normally functioning, then the patient can raise the arm above the level of the head. There will be associated wasting, especially in the suprascapular and infrascapular area of the spine of the scapula, and there may be diminished power of abduction. Why? Because supraspinatus starts the abduction, and after beyond 20-30 degrees, the deltoid can take up the function. How to diagnose it? Diagnosis could be with use of an MRI. If you see it over here, this is a fluid collection in cyst. If there is associated with some kind of a cyst which is impinging on the nerve, that could be seen on the MRI, or it could be seen on ultrasonography. So to assess how much nerve damage has occurred, we can go for electromyographic studies and measurement of nerve conduction velocities. Treatment would include, depending upon whether it's what kind of injury. If it's neuropyrexia, that would eventually sort it out. We just need to give some splints and physiotherapy and muscle strengthening exercises so that the supraspinatus and infraspinatus does not atrophy over time. Then if we know that there's continuous compression, then we need to release the ligament which is compressing into the suprascapular notch, or we may need to do some kind of surgery so that the nerve does not get compressed in the fibroosseous tunnel. There could usually the approach is through a posterior incision approach, and it's going to be appreciated over here. The patient is doing a surgery. The posterior incision, the shoulder is approached posteriorly so that the fibroosseous tunnel at the spine of the scapula and the suprascapular notch can be dealt from posterior approach. In this section, we have briefly gone through the radial nerve and suprascapular nerve syndromes. We need to appreciate this that so a radial nerve can be damaged, and it could be a purely posterior interosseous nerve injury. It could be radial tunnel injury, which needs to be clinically evaluated and differentiated from tennis elbow, and this usually results in a severe form of the common extensor origin muscles can get paralyzed with atrophy. There could be loss of the extension at the wrist joint as well as the metacarpophalangeal joint, leading to wrist drop as well. And lastly, we have briefly gone through the suprascapular nerve, which is although very common but usually missed injury, and it can be associated with repetitive trauma or continuous compression at the suprascapular notch. Keep watching sqadia.com. Thank you very much.